Being a GIS guy in College of Public Health, I have already a lot of experience with convergence, practicing convergence. And so I'll be briefly just touching on some of the challenges that I personally have experienced in working with other disciplines and trying to kind of integrate what I provide into larger research projects. And from that, what I see as some priorities to try and improve that. So start with training. So this is drawn more or less from what I felt I lacked in my own education. I feel like we need to identify the core competencies for the next class of researchers. And one that just continually comes up is programming and computer science. I am scripting pretty much every day, and I only had, I think, 2 programming classes in all of my training, and so I use it constantly, and I'm constantly frustrated with how slow I am, and because I know people who are actually trained in computer science could do what I do on just the actual programming side of things much faster and much more efficiently, so that when they're running the models, optimization doesn't take nearly as long because they do it right the first time. Another just simple thing, I think we need to give more emphasis to training in multiple GIS suites. I think sometimes we get locked into Esri or open source without giving multiple options. This was driven home to me recently when we had a problem with our license server and couldn't get Esri products for about 2 weeks, so that was a problem. I think we definitely need to continue to emphasize statistics. So in medical geography, or rather, in public health, basically every single project has to have a biostatistician. Just from the get-go, that's a requirement. And there's basically no one in my entire university that does spatial statistics. So I have to be my own statistician, and that's a challenge. So that's something, for convergence, we need to make sure students who end up in my position are capable of taking on that challenge as we work to build up more capacity in other fields that work with us. And then finally, grantsmanship. This is an area that, again, is huge in public health and medical sciences broadly. And I received very little training in this coming up through GI Sciences. So that's just another area. I think if we want to make this a priority, we need to help our students know what they're going to be up against. All right, another area of priorities is terminology. So I'll go through these examples really quickly, just a few examples. What is a cluster? When is a cluster not a cluster? I created this map. This was cutaneous melanoma, and we took this back to our partners, and they said, what the heck is that? That's not a cluster. What can we do with that? That's useless to us. Another project, hotspots. I had a person come to me wanting to do hotspotting. They meant something entirely different. I'm thinking geospatial clusters, and this is based on the Camden Coalition in New Jersey, where it's focused on high needs patients and identifying the super utilizers and building a team-based approach to help reduce their use of emergency services, things like that. There's a spatial component, but it's completely different from hotspots. Another example, accessibility. Geographic accessibility, geospatial accessibility, spatial accessibility. These are not necessarily synonyms, though depending on who you talk to, they might be used as synonyms. So these confusions in terminology make it hard to effectively communicate across disciplines and even within our discipline. An example of this is just, what do we even call the field? So there are still researchers like myself that identify as medical geographers. There are others that identify as health geographers. There are some that have tried to merge them and call the field health and medical geography. People have tried to introduce new terms like geohealth. It's kind of a mess. Even within our discipline, we still have terminology problems. Okay, transparency. This is obviously a huge topic. I'm going it's a lightning talk, so I have to be very brief. But margins of error, just as one very common example in American Community Survey data, are enormous. Frequently, the margin of error is larger than the estimate. What do you do with that? In my experience, there aren't very many effective techniques for conveying uncertainty, at least visually in our maps and graphs. Mark Monmonier talks a lot about this in his book, How to Lie with Maps. It's not a new challenge, but it's one that I think we haven't solved yet. One approach that I find interesting is from Cronenfeld and Wong. They use cartograms, and you'd have to take into consideration the rate and the area in which the rate is manifested to try and visualize statistical significance through a cartogram. I find this very interesting, but it's still kind of confusing, so I don't think it's the solution. But I like that there are at least some people working on this area. I think we need to continue to make this a priority. All right, and then finally, just kind of broadly, I find one of the biggest challenges with convergent work in public health is there are lots of researchers across my university that want to work with me. They're excited about the possibilities of spatial stuff, but they don't really know what that entails. And so I think we need to improve our advertising. What do we offer? What can we bring to these other disciplines? So this was a project on screening mammograms across the state of Arkansas. I mapped the facilities, mapped the women. Okay, good, that's what I want. I added the travel times, blew his mind. Okay, this was just, they had no idea that you could do this. And it's not that advanced from a GI science perspective, but it was really, really exciting to my partners. Another one, this was in Egypt, looking at avian influenza. So we did basically just a habitat map for the virus. And we found that H5N1 and H9N2, so that'd be panel A and panel B, they are the two virus subtypes that are most common in Egypt. And a new emergent subtype was introduced a few years later, H5N8, that's panel C. And we were able to show that they have slightly different niches, and H5N8 is outcompeting H5N1 in the regions where they overlap. And so we can predict that H5N1 is actually going to go locally extinct in Egypt. We don't know if we're right yet, but that's what we're predicting. And then finally, I'm out of time, but this last one is looking at the opioid epidemic and looking not just at how many doctors a patient visits to try and get prescription opioids, that's doctor shopping, right? But doctor hopping, where we're looking at the travel patterns, how many prescribers they're skipping to get to the one they actually use. And we find that that's linked very highly with misuse. So I think we have a lot to offer, even in relatively simple analysis from a GIS perspective, but we just need to do a better job about advertising what we can offer. Thank you.